Test for balance. Remember, balance equals stability. Stability equals control, and control equals no movement. Therefore, when we're looking at balance, we expect there to be no movement. The two tests that we're going to do to determine someone's balance is the single leg stance, which is diagnostic, meaning that it will tell us where we need to treat, and it is also objective, meaning that there are norms that have been researched in the literature that we can use as a guideline for where our patient is expected to be. And the balance stability test, which is also diagnostic, telling us where a patient lacks stability, but it is not objective, it is subjective, meaning that both the therapist and the patient will be able to kind of feel subtle differences, but there's no objective way to standardize it, nor are there norms in the literature for it. Both of these are good measures of before and after treatment to determine if there has been a change in your patient. Typically, I use the pelvic stability test for my older population as it is a test that makes them feel more secure and stable when we're doing it. Single leg balance. I think all of you are pretty familiar with this test and probably perform it all the time with your patients. We're going to look at it in a slightly different way, as we're going to look where there is movement. Since balance equals no movement, we want to know where in the system is the patient moving within the foot, the ankle, or the lower leg to determine the area that needs to be further assessed to determine whether there is a structural or a non-structural dysfunction in that area. We will also use that motion area to perhaps use as a stabilization technique as part of the arms release technique if there winds up being structural dysfunctions elsewhere in the foot and ankle. Again, when we use the arms technique, we will want to stabilize the area that is unstable or moving so we can determine what location that would be using the single leg balance as well. Why and when would you use this test? You would choose to use this test as a before and after to show improvement of the intervention that you've done on your patient. Also, it is a quick objective screen for documentation. It's a great thing to use as a documentation tool, as it's been shown to be reliable and valid in the literature. You would use it on athletes whose sport requires balance, particularly single leg balance, like a dancer or gymnast. With a person that would ambulate with a short step length, maybe they are ambulating with a short step length because they lack single leg balance during the stance phase of gait. It would also be used to maybe determine why somebody might have bunions. If a patient stands on one foot and they have instability at the midfoot, the area of the bunion at the first metatarsal phalangeal joint or on the fifth metatarsal phalangeal joint may become mobile and irritated by the shoes, and that could be a reason why somebody has bunions. It will also show the therapist where there is instability in the foot and ankle, and then we will go back to our reasons for instability and determine why the patient has instability there. Here are the reasons that somebody might be unstable, and I put this in your handout. It is important that you know these things cold. So again, the reasons for instability would be upper motor neuron disease or injury, lower motor neuron disease or injury, alignment because structure dictates function, so it could be an alignment issue of the bones causing the muscles not to be able to fire as optimally as they could and causing instability. It could be inflammation. For every cubic centimeter of inflammation, a muscle shuts down by 1%. If it is in the joint, the inflammation, it will cause instability of the core muscles, as the core muscles are closest to the joint itself. Or lastly, severe atrophy. Be aware that 4 of the 5 of these will probably be in the patient's history, or if you find instability in an area like the knee and you're not aware of the knee injury, you can ask the patient, do you have a history of knee injury on the right? And they might remember something that had happened in the past. Otherwise, you will then take a look at the alignment of each of the joints to determine if it's none of the other 4, then it's probably an alignment issue, and there will likely be an underlying structural dysfunction that is causing the malalignment to occur, or maybe a leg length discrepancy, that's where we need to play detective a little bit to figure out why the alignment issue is happening. Here are the norms for the single leg balance test. And notice as the patient gets older, their balance gets worse. In fact, patients who are over the age of 80, on average or norm, have less than 1 second single leg balance. This is important functionally, as anyone over 80 will need to be tested to determine if they are safe to ambulate outdoors where they're going to be negotiating a step in the curb, as well as getting into and out of the tub. Both of these activities require single leg balance. So if they do not have a handrail in their tub and they lack single leg balance, they're over the age of 80, one might want to install one in the patient's home, and they might want to use a cane if they're going to be negotiating curbs outdoors. To perform the single leg balance test, a therapist will time how long a patient can stand on one foot using a stopwatch, and also observe how the patient is able to maintain a single leg stance. It is important that the patient is not wobbling all over the place, because that is not functional. They will not be able to negotiate a curb or get in and out of their tub with safety if they are moving all over the place. Remember, balance equals no movement. Here's some of the advantages to the single leg balance. It's a quick and easy screen. It's functional as it's needed for tub transfers and ascending and descending curbs, as we had just mentioned. It has been researched and we have norms. It is also objective. Time is one of the most objective measures that we have. It can also show us where we need to treat within the foot. Where is the foot unstable? And then we need to ask, why is the foot unstable? Is it because there's a structural dysfunction preventing the muscles from firing optimally due to the length tension ratio? Or is it a non-structural dysfunction due to something else, such as motor neuron disorder or inflammation? So again, we have to decide what is causing the movement within the foot. Additionally, it can be used for G-code reporting to determine the percent of normal, since we have norms, and we can then take the patient's information, compare it to the norms, and give us the percent limitation for an individual when we are billing Medicare G-codes. And here's the downside to the single leg balance. Some people cannot stand on one foot for greater than 1 second. Again, if a patient is over 80 years old, we would expect that. So if a patient cannot stand on one foot for greater than 1 second, you're going to record that measure as 0 seconds, and you're going to be able to observe them, if they are ambulators, by looking at how they perform the single leg stance phase of gait. So you will observe them taking a step forward and a step back to look for movement or quivering within the foot. This is a safer way to test balance in your older individuals, particularly if they are nervous about doing the test. Observing single leg balance. As you can see, there's movement initiated at the ankle of the right foot. Can you figure out the likely reason for this patient's instability? This patient is a 43-year-old active female, neurologically intact with no symptoms of arthritis. However, she has a history of ankle sprains. What is the likely cause of the instability? Given this patient's alignment and history of ankle sprains, the likely answer is that her instability is due primarily toward inflammation. On this patient, notice the motion initiating at the subtalar joint. Observing this patient's left foot, you'll notice that the movement is occurring right around that navicular area on the left. What do you think is the reason for this patient's instability? The patient is neurologically intact, 45-year-old male, no history of arthritis or trauma to the ankle or foot. Based upon this patient's history and looking at the structure of his foot, ankle, and leg, his instability is likely due to alignment. For this patient, the motion is occurring at the ankle joint, and when observing his right foot, he's not able to maintain single leg balance on that side for a significant period of time. But the motion occurs at the navicular and the arch. Given that the patient was not able to maintain balance on the right, we're going to observe the stance phase of gait. So watch him as he moves his left leg forward and back and weight bears on the right foot. Stance phase of gait is about 0.7 seconds, so we're going to look for appreciable movement during the stance phase of gait. We do not see appreciable movement there. He has sufficient balance for walking, but not single leg stance. This patient is a 68-year-old man with no history of trauma or surgery to his foot and ankle. He is neurologically intact. What do you think is the reason for his instability? For this patient, the likely cause of instability is alignment, looking at his foot, ankle, and lower leg position. When would you perform this test? You would want to do this test to show improvement before and after treatment for both you and the patient so that they could feel the difference of the intervention. You would use this to determine whether orthotics are indicated or would benefit the patient. So you would test with and without the orthotic intervention and see if putting in the orthotics would make the patient more balanced or more stable. It can also be used to determine the stance position that the patient is most stable in for ADLs. So let's say you have an older patient who's at a risk for falls and they're standing on line at the grocery store. You could tell them which foot they will benefit from having in front with regard to stability and balance, or if they're on an elevator, something along those lines, they might be more stable with their right foot forward or their left foot forward, and you can determine this using the pelvic stability test. When a force is applied gradually, and it's important that it is performed gradually, the tester can determine a weaker lower extremity, right or left, and what areas of that lower extremity present with instability. The positive test is movement. So when you apply your force, if there is any quivering or movement, that means that there is instability in that area. And you will be testing the pelvis, the hip, the knee, and the ankle, both on the right and the left when the leg is in the forward position as well as the back position. As I mentioned, it will tell us where in that anatomical sequence the patient is unstable, and then we'll have to figure out why they are unstable. And from this information, you can choose if you are going to release and need to release using the arms technique, where you can apply your position of manual stability. And we'll get into the arms technique when we deal with treatment. How would you perform this test? The starting position is the therapist can either choose to stand behind the patient or in front of the patient. The patient is then instructed to take a normal size step forward. So monitor the step, make sure that it looks normal to you. If not, have the patient retry. And also note that if the patient is very unsteady or nervous, have something available near them that they can grab on should they feel unbalanced, like a sturdy piece of furniture, perform the activity near a wall, or maybe if you're standing in front of the patient, you could have a chair or a bed behind them as you do this test. The therapist can stand either behind or in front of the patient. If the patient is in front of the therapist will step forward with the same foot as the patient. If the therapist is in front of the patient, they will step forward then with the opposite foot. The therapist will then place the heels of their hands on their iliac crest of the patient, and the therapist's fingers are pointed downward. So you would be in ulnar deviation of the wrist. The therapist needs to stand close to the patient, no further than a forearm's distance from the patient. And then the therapist should look at the structures that they are going to treat by moving their head down or utilizing a mirror in front of the patient or at the side of the patient. Your command to the patient is hold, don't let me move you. After you've instructed the patient to hold, don't let me move you, the therapist will just lean their upper body weight into the patient's pelvis with a directional force directly down. This will evaluate the pelvis. If there is movement or instability initially, it might tell you that is a higher portion of the pelvis, something like L5, S1, or something high on the pelvis. If it occurs a little bit later, it might tell you that there's instability at the pelvic floor or something going on at the coccyx or the ischial tuberosities that might need to be addressed. The therapist will then increase their force by about 25% to address instability at the hips. And again, if you increase your force 25%, you will now be at the hips. Be aware that you will not lean into the pelvis and then relax. No, you will lean into the pelvis, address it, and then increase your force 25%. You will never let up on your force. Now we will increase another 25% with a directional bias, either anterior or posterior. You will gain that directional bias by bending your knee and lunging either anterior or posterior. Do not use your arms because it will create interference and you will be less able to judge instability in your patient through tactile means. At this point, you are now evaluating the patient's knee, either their anterior knee, if you are biasing anterior, or their posterior knee. So now you can determine differences between right and left. And finally, you will increase another 25% with your anterior or posterior bias, whichever one you have been testing. Don't switch on the patient to determine instability at the foot and ankle. At this point, once you know there's instability, you will need to determine why there is instability, and we'll get into that a little bit later on. Patient and therapist take a step forward with the left foot. Therapist places hands on iliac crest, fingers pointed down. Command, hold, don't let me move you, and therapist leans her weight into the patient's pelvis. We will now look for movement at the pelvis. Therapist increases her force and now is coming forward with the knee to test the left knee and the left foot, respectively. When the therapist stands in front of the patient, the opposite foot follows theirs. The commands and hand placement are the same. The therapist begins to lean at the pelvis, and we will see some movement at the pelvis. And as she increases her force with that knee bend, we will also see significant movement at that left knee and both feet. This is an unstable position for the patient at the pelvis, the knee, and the hip. Here is a quick interpretation of the test as we have just described it. So the amount of force that you put in will equal the evaluation of the following. When the therapist leans into the patient's pelvis, you are evaluating the pelvis. As you are leaning into the pelvis, you will then increase your force by 25% and evaluate the hip. After, increase your force another 25% and you are at the knee. And a last 25%, you will now be evaluating the foot. Again, if you are biasing forward, you will be evaluating anterior. at the hip, knee, and ankle, or if you are biasing posterior, then you will be evaluating the posterior hip, knee, or foot. Pelvis will always be the same. Here's some important things to note about the interpretation of this test. And this little test can tell you a lot of information about what's going on with your patient. Firstly, remember, this is a subjective test and should be used primarily for diagnostic purposes. So it is going to tell you where there is instability in the system of your patient. Then you can also document it as a result of a static standing balance test and rate it as you would good, fair, poor, with a plus or minus attached to it. Be aware that sometimes you will feel instability initially that will improve with increased force when you test down the kinetic chain. And you also might have instability at the pelvis, and then stability at the hip, and then instability at the knee, and stability at the foot. So there might be multiple locations of instability. When you determine that an area is unstable, well, now we'll need to determine why. Remember your reasons for instability: upper motor neuron disease or injury, lower motor neuron disease or injury, severe atrophy, inflammation, or alignment, and figure out which is causing the instability or the movement in your patient during the single leg balance test and the pelvic stability test. Here are additional things that you should consider when performing the pelvic stability test. If the therapist is shorter than the patient, you are encouraged to stand behind the patient. You will have better control there. If there's a very large height discrepancy between the patient and the therapist is encouraged to stand on a step or use a high-low table, something along those lines, so that you can have better mechanical advantage. In order to best visualize the motion, the therapist should use a mirror, or if the mirror is not available, choose to stand in front of the patient if it's appropriate, to be able to visualize motion of the lower body, because some people don't have great tactile perception yet, and they will not be able to feel subtleties in movement, but you can sure as heck see them. So use your mirror or choose to stand in front of the patient when you're performing the test so that you can actually see where you are engaging your force to determine whether there is motion there. It either moves and then it's a positive test and they are unstable there, or it doesn't move and they are not unstable and therefore do not need to be treated at that area.